All right. If you're just joining us, good evening and welcome to today's discussion. Today is day 6 of our internal medicine primaries discussions, particularly for West Africa. However, national candidates are also welcome because this is internal medicine after all. Although the MCQs, are going to be different, but there's no how you will not benefit something from being in this class. All right. Um, we'll start from where we stopped yesterday. So the first question on my list here is cardiology. So what's the cause of fixed splitting of the second heart sound? The question has only two options. Option A is aortic stenosis, and option B is right bundle branch block. So you can comment your answers. Please don't move it around. Dr. Musti, please don't move it around. Don't move anything. Don't distort our discussion. Don't move anything. Just leave it. I need to make my system stand. Put your phone in landscape mode. You see it clearly. It will be bold and big. And you can also read it from the chat in the on this app, this there's a chat box within it. That's where other candidates are commenting their answers, what they chose. Okay. So before we get into the answer to this question, we're going to use airbody a lot, particularly for this question. But before we get there, um, when you talk about heart sounds, you have to know there is a first heart sound, there's a second heart sound, there's a third heart sound, and there's a fourth heart sound. So, and each of them have something they mean, and these are potential questions for your exams. So, what does the first heart sound denote? This is the heart. Let me just use a simplified version, a simplified image of the heart. Okay, I'll use the red color to make it a bit more distinct, right? So I'm just going to use a heart like a random person, right? So we'll divide the heart into four parts. Okay. This is not how the heart looks, so but just for the purposes of this discussion, we're going to draw it as if it's the heart. Now here there will be a valve. Okay, this is the right side. First of all, establish this is the right and this is the left. So there's a valve here. There's also a valve here. Okay. And there are valves everywhere. Okay. So All right. So what does, please click on the whiteboard. You have to put on your whiteboard first of all. If you're just joining us for the first time, what you need to do is to go to the options. When you go there, you see a place where they write show whiteboard or just whiteboard. You click on it. And when you click on it, that's when you can view what we are doing. Like you can now view the whiteboard and see what I'm writing on it. And when you finally open it, please don't drag anything, don't write anything. Just let it be the way it is. Just be looking at it the way it is. Because when you move anything around, it distorts the discussion, right? I just finished saying it, Lawa, you're already highlighting something. Don't do anything, don't drag anything, just leave it. All right, so where I'm pointing at now, let me change the color. Where I'm pointing at now, so which chamber is this that I labeled one? All right, so I'll just be using the numbers. I just finished giving direction on how to access the whiteboard. Go to the options, you will see where they write show whiteboard. Then you will see it on your screen. Please, number one, which chamber is number one? Please, let's move. You can type, you can comment. Which chamber is that? Anatomy students, let's flow now.
The right
This is
atrium.
this is normal class now. Why
Right
is everybody
atrium.
quiet?
Right atrium.
What?
The right atrium.
Okay, okay. Yeah, so that's the right atrium. Of course, it is. I've been giving you like a clue by writing right, the anything where it's right and left. So obviously this is the atrium, so it's the right atrium. And then um why is everybody saying they cannot see now? The same process that we've been using before. Go and click, check your options. You'll see where they wrote show whiteboard. You click on to show your whiteboard, then make sure that you have selected the whiteboard among the options, the list of, you know, the list of names. One of them is whiteboard, so make sure that's what is on your screen. Yeah, you'll be seeing it. All right. um so yeah, that's the right atrium. Then number two is what? This is number two now. Which chamber is this? Let's flow now. I'll leave it to, okay, let me just leave it.
Left atrium. No, sir. It's left atrium. Number 2 is left atrium.
Okay. Yeah, number two is left atrium. So right ventricle, right atrium, left atrium. Number three is right ventricle. Number four is, left ventricle. So what's number five? Listen here. The stuff that
It's a
connects
tricuspid.
number one to number three.
It's a tricuspid valve.
Yeah, that's the tricuspid valve. If you notice the way I drew it, there are actually three cusps. That's the meaning of tricuspid valve. So there are three cusps. Then number six is joining number two and number four. It's bicuspid valve. Okay. also known as the mitral valve. So mitral valve is on the left, tricuspid is on the right. Okay. So that's the you know, what do you call all those valves? Like they are the valves that connect the atrium to the ventricle on
Atrioventricular,
both sides. What?
atrioventricular valve.
Retroventricular
Okay, yeah,
valve.
AV valves. Yeah, so they are the valves that connect the atrium to the ventricles. Then on the other side, we have number 7. Okay, so if you identify this vessel, this is the aorta. Okay, if this is the left ventricle, then this is the aorta, and this is the what? This is the pulmonary.
Pulmonary vein. Vein.
Yeah, this is the pulmonary vein. Okay, so there's a valve here too, and there's a valve here too. So these are the outlet valves. Okay, they are the outlet valves. So they um they connect the heart to the outside, right? They connect the heart to the outside and all that. So if these inlet valves, these atrioventricular valves, when they close, that's what makes that first heart sound. Okay, so that's okay. That one closes, and first of all, blood comes in, rushes into the atrium. The atrium contracts, pushes blood. Okay, as soon as it contracts, the atrioventricular valves open, bicuspid and tricuspid. So blood now rushes into the ventricle. As blood is rushing into the ventricle, the pressure in the ventricle builds up, and as the pressure gets to the critical level, it's overcomes the ventricular pressure and then closes the valves. So the atrioventricular valve now closes, and when it now closes, the ventricle starts contracting. Okay, so as they are contracting, they will now open up the outlet valves, okay, to push out blood through the aorta and all that, right? So as that is happening, you know, the yeah, as that is happening, then the you expect. Why am I getting confused? Okay, as that is happening, then you expect the valves here to open. Okay, after a while, when the blood has finished flowing, the pressure in the ventricle now drops. So the outlet valve now closes again. So the closure of the outlet valve now creates the second heart sounds. So that's heart sound 1 and heart sound 2. So what creates the third heart sound and the fourth heart sound?
Thought heart sounds rapid to slow feeling. Slow to rapid feeling of ventricle.
I don't know why I can't really make out what you're saying. Are you using a microphone?
No, slow to rapid feeling of the ventricles.
Yeah, rapid ventricular filling. Rapid ventricular filling can cause third heart sound. Dr. Gu, if you can go ahead.
Chief, please, I cannot see the whiteboard. I cannot see what you are drawing since, so Chief.
What have you done to see it?
I clicked on the show whiteboard and I'm not seeing anything, sir.
Have you seen? Are you seeing a white screen?
Yes, I saw the white screen. I saw
Okay, wait for
I
it
clicked
to
on it
load.
there.
Depends on your network. If you are seeing the white screen, it means it's empty. So it's going to stream the content into it, and then you start seeing it.
Okay, sir.
All right. So what about the fourth heart sound? Third heart sound, something about it. I think it can be normally like in a lot of people, like children, old people, pregnant women. you know, eh, because of that rapid ventricular filling, right? But the fourth heart sound is always said to be always pathological. So what causes the fourth heart sound?
Right bundle branch block.
A
Arterial contraction. Arterial contraction.
It's right bundle branch block.
A fourth heart sound is an abnormal late diastolic sound that occurs due to forcible atrial contractions in a non-compliant ventricle.
Okay, yeah, atrial contraction. Okay, that's what causes the fourth heart sound. But before we continue, let's go to air body and
Finally, I'm seeing something.
so list the heart sounds and their meaning and causes for the pathological ones. So if you're not using air body, you're doing yourself a big disservice in your study. So the first heart sound is heard at the beginning of systole, right? In fact, it represents systole. That's why when you want to, when you are listening to the heart, okay, and you want to know which one is the first heart sound, you will you place your finger, okay, at the carotid to know the sound that coincides with when you are feeling that trail at your at the carotid, right? And so that gives you an idea because that thrill you are feeling at the carotid coincides with the contraction, the ventricular contraction, and that ventricular contraction coincides with like almost with the time when that first heart sound. That's as soon as ventricle contracts, the valves close, and it gives you that sound, and then you feel that pulse on the carotid, right? So that's the idea behind it. So that's the first heart sound. Then the second heart sound is the second one that you hear. Okay, so if you hear a lob, after the lob, you hear a lob. So lob dub, lob dub. So dub is the second heart sound, and that's as a result of closure of the what aortic and pulmonary valves, which are the outlet valves. Then the third heart sound, like we said, occurs at the beginning of the diastole. Okay, so second heart sound occurs at the end of systole. Third heart sound occurs at the beginning of diastole and represents rapid ventricular filling, okay, of the ventricles. Can also be pathological in people that have heart failure, cardiomyopathy, like things that cause that rapid ventricular filling. But it can be normal in a lot of people, like children, old people, and also pregnant women. Okay, so cardiomyopathies, mitral regurgitation can cause loud S3. Then fourth heart sound, uh, heard at end of the diastole, okay, and represents atrial contraction. Uh, Causes of pathological S4, we have cardiac disease, you know, aortic stenosis, hypertension. So these are some of the things to take note of when you are talking about the heart sounds. So also discussing the heart sounds leads me to murmurs. Okay, so um, there's something I use, a mnemonic that I use that has always worked for me. So when you are discussing murmurs, pass and then paid. So once you think of murmurs, think of pass, paid. You cannot go for a medicine exam, even any exam, any common medical exam for that matter, without meeting murmurs in one form or the other. Okay, because they love it. So This is a simple way to code and be able to get which one they are talking about at any point in time. So pulmonary and aortic stenosis, are systolic murmurs. Okay, pulmonary and aortic incompetence are diastolic murmurs. So you've gotten the code. So the reverse is true. So if pulmonary and aortic stenosis are systolic murmurs, it means um, what's the other ones? Mitral and tricuspid regurgitation or incompetence are also systolic murmurs. And if pulmonary and aortic incompetence are diastolic murmurs, the reverse is also true. It means mitral and tricuspid stenosis are diastolic murmurs. Simple and short. Do you get? So if you have this at the back of your mind, you will always be able to tell where murmurs are coming from. So because we are talking about pulmonary and aortic stenosis, if you talk about systolic murmurs have uh, early systolic and late systolic. Okay, and diastolic murmurs have mid diastolic and late diastolic. Okay, so based on that, pulmonary and aortic stenosis are going to be early systolic murmurs. Okay, while mitral and tricuspid regurgitation are going to be late systolic murmurs. On the other hand, pulmonary and aortic incompetence are mid diastolic murmurs, while mitral and tricuspid stenosis are late diastolic murmurs. So just something like that, you know, that gives you an idea of the different types of murmur and where they belong. And then another thing to note is this. This is this is a human being now. The head and the neck. This is the chest. This is the body. Okay. This is the arms. This is the chest. This is the arms. This is the chest. Okay. So this is the areola. Okay, which coincides with the fourth intercostal space. So we used to use, if you're a Catholic, you understand this code, all pray to Mary. So APTM, that's basically saying that if you want to localize where a murmur is, like if you listen to someone's chest and you hear a murmur, okay, so just based on the local, because every murmur has the 5 characteristics. There's a location, there's a radiation, there's a intensity, you know, all those things are pitch, loudness, all those things, they are all characteristics of a murmur. Okay, so if you listen to someone's chest and you hear a murmur, let's say in this area, in this area now, this where I wrote the A is the second intercostal space on the right. Remember that the heart is on the left. Okay, this is the sternum somewhere here. Okay, so the second intercostal space on the right means is likely going to be an aortic murmur. So that aortic murmur now, depending on whether it is systolic or diastolic, will now tell you whether it's an aortic stenosis or aortic incompetence, right? But just know, like if you see a murmur here, a murmur that is loudest at this aortic area, it means it's an aortic murmur. And usually aortic murmurs radiate to the neck because obviously it's closer to the neck. So aortic murmurs usually radiate to the neck, right? Then if you see a murmur at the second intercostal space on the left, because these are the things that they will test you for in the MCQ. If you see a murmur on the second intercostal space on the left, that's a pulmonary murmur. It may be a pulmonary stenosis or a pulmonary incompetence. That's the murmur that is loudest at this point, because sometimes murmurs can also be heard in multiple regions, but you now check where it is loudest by placing your stethoscope along all the different parts where you expect the murmurs to be. Okay, that will tell you which murmur it is. And then based on the timing, is this systolic or diastolic and some other factors, you'll be able to tell what type of murmur it is. Then a murmur that is here on the around the fourth intercostal space, parasternal border on the left, okay, that's likely a tricuspid murmur. Also VSDs usually relocate to this side too. Ventricular septal defects, okay, they also relocate to that place where the tricuspid murmurs are, okay. And anything that you do for tricuspid regurgitation, you also know that it's going to happen for VSD as well. Then mitral, we know that the mitral valve is coincided with the apex of the heart. So it's usually heard around the place where you expect the apex of the heart, which is in a normal heart supposed to be at the fifth left intercostal space, mid clavicular line. So that's where you expect the mitral valve to be. So that's also where you are going to hear the mitral murmurs, which can be mitral stenosis or mitral regurgitation, depending on the timing and some other factors. And usually, mitral murmurs radiate to the axilla, because these are some of the pictures that they'll paint for you in the MCQ. So they can paint a picture and then tell you that the murmur radiates to the axilla, gives you the timing, give you everything, and then it's for you to now ask you what type of murmur is this. They now put their options. So it's now left for you to be able to use your past page, use your all pray to Mary, use your radiation knowledge, and then to identify what type of murmur it is. Like I said earlier, please don't move anything, don't move things around. You are distorting our discussion. Don't like when people don't listen. See now. You spend time I'm supposed to use for discussion to rearrange the slides, because I'll still paste this thing in your group chat. So if you are rearranging it, you are going to make it. If I paste it the way it is, if you distort it, it's you that will still suffer it, because like it will not be clear to you when I paste it. So don't rearrange it, just let it be. All right. So that's that about the murmurs. Just some tips about it. You should be able to answer questions on murmurs based on these tips. Okay. So the next question. It says, strep sanguinus is found in the mouth, skin, pancreas, kidney. So which of them is correct? Let's try and answer the question so that we can move. If you have doubts, you can ask everybody. Okay, we didn't actually answer the first one. All right, so yeah, it's found in the mouth. The first question, fixed splitting of the second heart sound is found in right bundle branch block. Okay. So all those splitting of heart sounds, um, fixed splitting, of S2, because what the second heart sound is actually, because there are two valves, there are two outlet valves. So there's A2 and there's P2. In a normal person with quiet breathing, the two sounds, they sound at the same time, right? So A2 and P2 will sound at the same time. So there's no splitting in a normal, under normal circumstances. Okay. So, but sometimes there can be splitting. Is it during exercise, or like when you inspire during inspiration? Okay, there's an explanation for it anyway. Like when you inspire, the pressure, intrathoracic pressure increases, blah 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 blah. There's an explanation for it. But during that inspiration, you expect some splitting. So you now see some delay between the A2 and P2. So A2 comes first before the P2. Okay, so that's the normal thing. A2 before P2. Then fixed splitting is like in right bundle branch block. Okay. Eh. So it means like there's delayed activation of the right ventricle. So A2 still comes before P2, but is bigger than it's supposed to be. So it's now noted. Then wide splitting is in atrial septal defects. Okay. If there's increased flow across the pulmonary valve, so you see that in wide splitting. Then there's one that is called reverse splitting that will occur in left bundle branch block, because it will now be P2 before A2. Do you get? Normally it's supposed to be A2 before P2, but now it will now be reverse splitting. So it means there will be P2, that's the pulmonary valve will close and make that sound before the aortic valve will close and make its own sound. And so that occurs in left bundle branch block, which means that the left side of the heart is delayed. The left ventricle is going to be delayed. So the right ventricle now comes before it and closes before it. So that's what happens there. So if you're able to just take, these are just some of the few things you should take note of concerning that. So the answer here is mouth. And the answer here is right bundle branch block. It's because of fixed splitting. All right. This next question is on pulmonology. Just testing your knowledge of vital signs in pulmonology. Increased vocal fremitus is in which condition? Option A, hemothorax, atelectasis, pneumothorax, effusion. I've asked this question before. Yeah, pneumothorax. Just like when you have a container and the container has water, it sounds dull, right? And when there's no water, when there's nothing in the container, just air, it's going to sound louder. Okay, so that's loudness, the way it sounds, the container sounds, that's what is regarded as increased vocal fremitus. So when you tell the person to say 99 or moi moi, words with high resonance, to give you an idea. In which condition do we see dullness? Another question on biotransformation. But I think we've answered the ones. Yeah, consolidation, you hear dullness. So when do you hear stony dullness? Yeah, pleural effusion, hemothorax, you know, hydrothorax, all those stuff will give you stony dullness. Okay, so phase one biotransformation reaction, we have options like isomerization, hydroxylation, acetylation, and conjugation. We'll discuss this thing very well, so you should be able to answer it. Have you guys answered? Okay, we're having B, 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 B. Yeah, hydroxylation, oxidation, those are phase one biotransformation reactions. Why these ones are phase two? Conjugation, anything like conjugation, sulfation, all those things are phase two. All right. So, which of the following is not a symptom of cauda equina? Saddle anesthesia, urinary retention, hyperreflexia in the lower limbs, bilateral leg weakness. Cauda equina. So what do you guys think? We have someone choosing urinary retention, choose bilateral leg weakness, someone choosing hyperreflexia. Let's make our choices so that we have varied answers. Option D, bilateral leg weakness. Okay. Those are symptoms of cauda equina. I've mentioned cauda equina somehow in passing previously. Cauda equina, what does it mean? Just basically means like as the nerve fibers are exiting. I mentioned that equina is like tail of the horse. So this is the end of the nerve, the conus of the nerve, okay, spinal cord. So there are nerves that are exiting it like this, spreading out, like the tail of. If you've seen the tail of a horse before, nerves spread out like this. Hairs. So that is tail of a horse. That's the meaning of cauda. Cauda is tail. Equina is horse. Okay, so cauda equina. So like tail of the horse. So if anything affects these nerve roots as they are exiting the spinal cord at the lower this thing, S1, S2, S1 to S3, S1, 2, and 3. Okay, it's going to cause what is known as that cauda equina syndrome. And we know that these things are particularly involved in perineum and the lower limbs. So it's going to be affecting the anal sphincter, it's going to be affecting the urinary tract, okay, the urine, okay, and it's going to be affecting what else again? The lower limbs. So the person can come with paraplegia, can have a saddle anesthesia, which is the perineal area, basically losing sensations. The person can have fecal incontinence, fecal retention, all those stuff. Basically, like the sphincter losing its control. So same thing with urinary retention, urinary incontinence. All these things can happen, but we expect the one that is obviously wrong is that we expect, because it's a lower motor neuron lesion, we expect a hyporeflexia in the lower limbs, not hyperreflexia.
I
Okay,
see, sir.
so that's why option C is off. Which of the following is not a structural cause of back pain? You have lumbar spondylosis, spondylolisthesis, spondyloarthritis, fibromyalgia. So which is not a structural cause? Okay, I haven't put up a question. Yeah, that's the obvious answer. Fibromyalgia. There are some questions like that should be a bonus. Like when you see it, you just be happy because like there's no how you feel it. What's the likely cause of pleural effusion? Let me break this. What's the likely cause of pleural effusion in patients undergoing continuous renal dialysis? Volume overload, peritoneal fluid leakage into the pleural cavity, infection, pulmonary embolism. Okay. In dialysis, there are two types of dialysis. There is peritoneal dialysis and there is hemodialysis. And usually, when you are doing hemodialysis, is usually, how do you put it, periodical, right? That's the one you do 2 to 3 times a week and all that. But peritoneal dialysis is usually like pre-installed, so it's like a continuous dialysis. Okay, as even if the person is sleeping, the person is walking, the person is, yeah, sitting down, the dialysis is ongoing. So that gives you an idea of what the answer should be. So option B is the answer. Also, one of the complications of that peritoneal dialysis is like peritonitis, because they are prone to infections from that. Let's see the next question. It's about a pregnant woman. Don't think you can escape O and G just because you went to internal medicine. They'll still catch you. A pregnant woman with GCSPD deficiency and UTI caused by E. coli should avoid which of the following antibiotics? Option A, nitrofurantoin, cefuroxime, amoxicillin, fosfomycin.
Nitrofurantoin.
Yeah, sulfur-containing medications are usually a problem. Are usually a problem for GCSPD deficient patients. Also, as a way of broadening the topic, what are other triggers? Because the thing about GCSPD, that's glucose 6-phosphate dehydrogenase deficiency. The thing about it is that, like, under normal circumstances, the patient is normal, okay? Because this enzyme is supposed to be involved in pentose phosphate pathway, okay, or hexose monophosphate pathway, HMP or PPP, right? So pentose phosphate pathway or HMP, that's hexose monophosphate pathway. And this pathways, they are the same thing anyways. It's plus or minus. This pathway is particularly useful for removing toxic substances from the blood, right? And so it mops up all those toxic reactive oxygen species and all those type of stuff by producing all those phosphates. Okay, so if the person is not able to is lacking this enzyme, okay, now these things are available, they are there, they're not doing anything. But when they are triggered, okay, if they're not there to remove those toxins, then red blood cells will suffer the consequences, because you now start having hemolysis and other problems, right? So that's the issue with GCSPD. Now there are particular triggers, and like every other thing, including sickle cell disease, GCSPD, they're usually triggered by infections, dehydration, uh, dehydration are like the major listing. Okay, some are triggered by cold or rapid changes in temperature and things like that. But particularly GCSPD, there are special foods and medications that trigger GCSPD okay, deficiency crisis. Okay, so there's a food called fava beans, okay, or big beans. I don't know the other name for it, but it's also implicated in this condition. Camphor, that smell of camphor can trigger um, crisis in GCSPD deficient patients. Anti-malaria medications, anti-malarial, sulfur-containing medications, all the sulfonamides and so on and so forth, anti-malarials, you know, especially the ones that contain sulfur. Yeah. So that's basically that about it. So nitrofurantoin is implicated. Also, it's important, when it comes to pregnancy to know which medications to avoid. Okay, so in every class of medications, there are medications that you must avoid in pregnancy. So if you talk about antibiotics, there are antibiotics you must avoid in pregnancy. If you talk about antihypertensives, there are lots you should avoid in pregnancy, and there are some that are known to be safe in pregnancy. If you talk about antipsychotics, if you talk about medication for thyroid disease, that's hyperthyroidism or Graves' disease, there are some medications that are useful, and there are some that you have to avoid. And there's even you can use one in the first trimester and then avoid it in subsequent trimesters. So these are some of the intricacies that are involved. Like in hyperthyroidism, um, normally in a normal patient, you want to use carbimazole, metimazole for them, right? But uh, in pregnant patients in the first trimester, you have to substitute it because it's harmful to the fetus in the, it's teratogenic, not teratogenic, but like harmful to the fetus in that first trimester. Okay, so but it's safe in the second and third trimester for carbimazole. So in that first trimester, you have to use what's this other medication? There's another medication you have to use in place of that. Then in second and third trimester, you can now go back to carbimazole. So that other medication, you ask, why didn't you just continue that one throughout the second and third trimester? That other medication has
Chief,
high
that one is propyltyrosine, Chief.
proprietary. Yeah, okay, PTU. All right. So yeah, PTU. It has high hepatotoxicity, so you cannot use it for so long like that. So if you use it beyond 3 months, you run a risk of serious hepatic harm. So you want to avoid it by using it just for that 3 months when it will cover for that teratogenicity and risk of during organ development. So after that, you can now continue with your carbimazole and metimazole. So these are some of the things to take note of. So in this patient that has UTI and is pregnant, which anti-malaria will you avoid?
You want to avoid fancida.
There's an option there, so you cannot just manufacture options.
Oh, sorry, I didn't see.
And fancy that is not an antibiotic.
Yeah, B. Trimethoprim.
Oh, you guys were not hearing me. No wonder. So minimal
Not at all,
changes is
Chief. Not at all.
you can hear me now. Oh, sorry.
Yes.
Minimal changes is the one that has the best prognosis, and it responds to prednisolone very much, and uh, is found in the pediatric populace. So when you see a pediatric patient with um, nephrotic syndrome, think of minimal changes. And then for some of you that still needs refresher for your renal disease, we have nephrotic